our childhoods to the extent that they kind of can mess you up quite a bit. If they don't get corrected for, then these dynamics, dysfunctional ones, will be played out. But whatever the starting point, this is for everybody. We help to advance them from rigid defense to more flexible adaptation, with it being understood that there are adaptive components to defenses and there are defensive components to adaptations. And the combination of awareness, acceptance, accountability can take the person pretty far.
You have found the Thinking Mind podcast.
Today on the podcast, I'm talking to Dr. Martha Stark, who is a psychoanalyst, a long-serving faculty member at Harvard Medical School. She's also been involved with a number of psychoanalytic institutions, including the Center for Psychoanalytic Studies at William James College, the Boston Psychoanalytic Society and Institute, and the Massachusetts Institute for Psychoanalysis. She has also written 9 books on psychodynamic theory and practice. Today we specifically discuss one of her books, Modes of Therapeutic Action. I want to talk to Martha because she spent a lot of time thinking about how exactly psychotherapy works, regardless of the school of thought. What is it that allows for people who go through psychotherapy to actually make deep changes? And she's done a really nice job of weaving together lots of different pieces of theory to make it intelligible. Now, this is not an entry-level conversation. This is quite an in-depth conversation, but regardless of your background, if you're interested in psychotherapy, I would encourage you to listen, maybe listen to it a couple of times over. I myself have listened to it a couple of times. It's a very rich conversation with a lot to learn, and I really enjoyed talking to Martha. Once again, thank you to everyone who has bought us coffees. We really appreciate it. I'll just give some shout-outs. Thank you to Nick, thanks to Larry, thank you to Ali and Edge once again, and I'll just read through some comments. Good morning, team. Just a small acknowledgement of the effort you all make in putting together these podcasts. Really helpful content and much appreciated from all the way over the other side of the world in New Zealand. This podcast has been unbelievably useful. I wish there were 1,000 more episodes. Thanks so much for the ongoing support. We really appreciate it. It helps keep the podcast going. And now, without further ado, here's Dr. Martha Stark. I'm tremendously pleased to be speaking to Dr. Martha Stark. Dr. Stark, thank you so much for coming on the program.
I'm delighted to be here, Alex. Thank you for having me.
One of the things we discuss quite frequently on the podcast, and one of the things I like to think about, is the way psychotherapy works and the way different schools of thought compare and contrast with each other. Psychoanalytic, cognitive behavioral, person-centered, you name it. And we recently started discussing your book in my therapy school, your book being Modes of Therapeutic Action. And I can tell you, me and my classmates all find it very interesting and also a very useful, what my tutor calls an integrating factor to help us understand, my therapist, shout out to my therapist who shall remain not named, calls you a meta-theorist, which I think is probably quite apt.
Oh, nice. Thank you. Thank you to your nameless.
My nameless therapist. So there's a lot that I want to talk to you about. But to start off with some fundamentals, why psychotherapy? I heard that you initially wanted to become a mathematician, and what a tangential journey must have been to go from mathematician to psychotherapist. So maybe you can tell us a bit about that.
Oh, I love that question. Thank you. So yes, I went to college majoring in mathematics, and I love sort of an analytic way of thinking, and I loved mathematics. But I found that when I was sort of doing the mathematics, and it was high-level mathematics that we were being taught, it was my major, that it was incredibly exciting and challenging to do, but it was at such a remove from my life as I was living it. And so there were two sort of separate somethings, and it seemed like not a very efficient way to be living my life. So I decided, though I still majored in math, to become pre-med, and I knew that I was going on to medical school. And even at that, I made the executive decision to become a psychiatrist. And then I knew I was going to become a psychoanalyst so that I could then be analytical using my sort of that mathematical part of my brain, my left brain, maybe in addition to my right side of my brain and my heart. So it seemed that ultimately becoming a psychoanalyst sort of captured the best of both worlds. Now, I knew that when I went into medical school, I was at Harvard Medical School, psychiatry was a little bit, seen as sort of a soft science. So when asked what my plans were, I sort of said, well, I was going to be a neurosurgeon. That was my thought. And they said, oh, that's nice. That's good. Anyway, so I'm not a neurosurgeon per se, but I do love to work with the mind analytically and deeply.
Yes.
So yes, so then I went on to do adult psychiatry residency for 3 years, and then a child fellowship for 2 years. So, and then I did my analytic training, and here I am.
So you went into psychiatry knowing it would be a leapfrog into psychoanalysis, is that right?
And that every moment that I was doing my work, seeing patients, clients, but I think I'll be saying patients, seeing patients and reading the literature and thinking about this, it was also broadening and deepening me as a person. And every moment of my living in the world was enabling me to be a little wiser and a little deeper and a little broader in my work with my patients. So it was a very efficient and pleasurable and delightful way to live, which is what I've done for these last 50 years.
I resonate with that. One of the things I like most about my work is that my work can inform my life, and that I can also mine my life for useful material from my work. So there's that synergy.
Oh, that's beautiful. It informs, the one informs the other. That was the word I was looking for. Yes, they inform each other. There's a mutuality of influence, mutuality of impact, and very efficient, very efficient.
You like efficiency?
I guess I do.
What do you think that psychoanalysis and maybe other forms of psychotherapy can get at? What can they do that psychiatry cannot do? So what psychoanalysis can do that other psychotherapies can't necessarily do is the goal, at least the way I do it anyway, and the way I teach it, is deep and sustained psychodynamic or characterological or structural change. So it's not just a kind of helping the person, manage a little better. You help them with their decisions, problem solving, and you share wise counsel with them, which is an important something, and that can be very helpful for some people. But the psychoanalytic endeavor, I think, is more a story about going deep. And it's an ambitious goal. And yes, historically, sort of it can take years and years. But I also think that more generally, a psychoanalytic approach, and I know we'll be talking more about that as we continue here, a psychoanalytic approach, which for me, and I don't even know how much I was emphasizing this back when I was writing Modes of Therapeutic Action back in the 1990s, but for me involves giving the patient optimally stressful interventions, just the right combination of challenge, which will disrupt, but then support, which will repair. The support in conjunction with the underlying resilience of the patient, the wisdom of their body, their innate capacity to self-correct in the face of challenge. Yes.
So for me, with the psychoanalytic approach is a story about, should I get into this here then?
Yeah, go ahead.
It's a story about advancing the patient, whatever their starting point, whatever their ego strength, we used to call it that, or not. Just, they could be stage 4 pancreatic cancer. Maybe they have a lot of PTSD. Maybe they're the walking wounded, whatever. Starting them, whatever their level of functionality, whatever their diagnosis, starting them where they are and advancing them through healing cycles of disruption in reaction to the challenge and repair or recovery in response to the support from your optimally stressful interventions, advancing them from, and now I'm sort of lifting this term from ACT, acceptance and commitment therapy, from psychological rigidity to psychological flexibility, or in the words of more psychoanalytic words or ego psychology, where Freud was talking about low-level defenses, which are more reactive and knee-jerk and mindless, to higher level defenses or more mature defenses or adaptations. So for me, whatever the starting point, this is for everybody. We help to advance them from rigid defense to more flexible adaptation, with it being understood that there are adaptive components to defenses and there are defensive components to adaptations. But more or less defenses, so I define defenses more broadly, not just repression and isolation of affect and compartmentalization, reaction formation, but rather defenses are what we do, all of us, what we do in the face of stressors, whether external ones or internal ones, what we do in the face of stressors that are too much for us to process, integrate, and adapt to. And instead, we, made anxious, get defensive. So we are bitterly complaining about things. That's a defense. We are always feeling victimized. That's a defense. It speaks to sort of old, bad reactivity that was probably critically important at the time. But if we are now reacting defensively like that as an adult, probably less too rigid, less.
It can cause problems.
More. Exactly, can cause problems. So talking about then going from psychological rigidity, the defensiveness, to adaptations, which I define as different ways. I can say adaptations are about making a virtue out of necessity. So in response to the stressors, the myriad stressors that are continuously coming our way, when we are able more reflectively, not reflexively, more reflectively, more mindfully,
more choicefully,
more choice, more intentionality, we will take it in our stride so that we can manage it. There's a song from way back by Gladys Knight and the Pips called Make the Best of a Bad Situation. And only people who are long in the tooth are going to understand that one. But adaptations are a story about making the best of a bad situation. Now, we want to advance the patient from being continuously overwhelmed to their being able to take things more in their stride, more flexibility.
Sorry to interrupt. This is Wolfgang Amadeus Mozart. And as a fan of the show, I'd like to encourage you to follow and subscribe wherever you listen. If you like the show, you can share it with a friend. And if you'd like to support the team, you can buy them a coffee using the Buy Me a Coffee link in the show notes. As always, they'd love to hear from you. So if you have any feedback, you can follow them on social media, or you can email the team at podcast@multilearning.com. So much there that I could pick up on, but one thing that you alluded to was the fact that stress is both the thing that we're immersed in all the time, and stress is the thing that can be too much. But stress is also the thing that is used strategically in therapy and psychoanalysis in order to induce an adaptive change, which my understanding is
in order to provoke an adaptive change. That's exactly right. Thank you so much for picking up on that. So two concepts that I guess I'm sort of known for a little bit are relentless hope and optimal stress. Come to find out, not all hope is good. Relentless hope, not so good. But optimal stress, not all stress is bad. Optimal stress, as you said, creates both impetus and opportunity for there to be initial disruption or destabilization of a dysfunctional system, dysfunctional defenses, not so healthy defenses, but then an adaptive restabilization, reconsolidation at a higher level of homeostasis, adaptive capacity, resilience, and cycles.
Yeah. What I love about this is that it corresponds so well to what we know about the physical body. And I love to make parallels between our psychology and our physiology. I like to lift weights, Martha, and one of the things, you learn when you start lifting weights is that the whole process is the weights break down your muscle tissue. It's a damage, it's a stress. But funnily enough, muscles have this strange feature that when they're broken down, if they're broken down not too much, then they grow back stronger. And isn't that like a wonderful thing? And it's so fascinating to me that our psychology does the same thing.
Thank you so much. In fact, I'm looking at a slide here and I'm going to reel off a number of things that are a story about in the realm of the physiology and the physical body. That in essence, what you're saying and what we're saying here is superimposing an acute injury, an acute physical injury, weightlifting and so on, running on top of a chronic one. So I'm going to reel off a number of names here and thinking that probably many of the people listening do some or even almost all of them. High intensity interval training, intermittent fasting. Intermittent fasting, by the way, is the one form of calorie restriction dieting that does not slow your metabolism down. Because during that window when you're eating, it speeds up your metabolism. And then admittedly, there's 16 hours when you're not, but you don't then have slowed down metabolism. So you can't ever really lose the weight, which calorie restricting diets tend to have a problem. It slows down your metabolism.
And my understanding is the metabolism remains high because during your fasting window, you have very low levels of insulin, which allows for the breakdown of fatty tissue. So there's nothing interrupting the metabolism of that.
That's right. Exactly. Okay. People can't see this, but you and I are both smiling broadly. All right. Ischemic preconditioning. Intermittent hypoxic training with breath work, vaccines and other immunotherapies, dermabrasion, Fraxel laser treatments, radiofrequency microneedling, platelet-rich plasma, platelet-rich fibrin, vampire gum rejuvenation, Botox, stem cell facelifts, ECT, transcranial magnetic stimulation, and the obvious one, cardiac defibrillation, sound therapy, acupuncture, acupressure, I'm almost done here, cupping, red light therapy, infrared saunas, brain teasers, mental exercises, and Sudoku.
Amazing.
To name a few.
So they're all forms of stress that produce an adaptive response. They're all forms of
stress that are ultimately, hopefully, optimal. And even just the learning process and the creative process and the developmental process, it's never a straight line progression from point A to point B, but rather these ongoing iterative healing cycles. Charles Krebs, a brilliant scientifically oriented healer here in Cambridge, Massachusetts, has in one of his books written the following sentence, which is just a beautiful sentence. Open, self-organizing complex, adaptive, chaotic systems. So chaotic systems, which we all are, resist perturbation, meaning disruption. So that if you do a little something, they basically, like, you have a rubber band and you like pull it out, but it snaps back. And the self-protective mechanisms, the defenses that our patients, that all of us reflexively resort to when in the face of stress, we're going to keep doing it unless there's enough impetus, which optimally stressful interventions will offer, enough impetus for there actually to be temporarily disruption and destabilization of that rigid, dysfunctional defense, such that that's the impetus. And then opportunity, right, for there to be the restabilization. And again, the restabilization will be at a higher level because it will be the synergy of external provision, external support from the therapist, and the internal reserves or resilience of the mind-body matrix, as I call it.
Of the patient.
Of the patient, right. The mind-body matrix, the living matrix, yeah.
I suppose the way someone like Jordan Peterson would put it, you're correctly riding the bounds between chaos and order.
Yeah. Yes.
Because we are, the interesting thing about, I'm sorry everyone if we're getting a little biological, but it's appropriate.
We just can't help it.
We can't
just
help it. You think about something as basic as a cell. We're all composed of billions of cells. A cell is literally chaos wrapped in order. The order is the cell membrane that keeps everything intact. But the way a cell works internally is very chaotic, in that molecules, enzymes, and substrates, lots of different compounds are bumping into each other in a chaotic way. And the membrane allows enough order and other structures in the cell. Some kind of containment. Some kind of containment in order to produce something viable and functional out of chaos. And that's all, as we are, as biological organisms, we are the things that produce some semblance of order from a wellspring of chaos.
Yes. Oh, I love that. Yeah, that's exactly right.
Yes. Now maybe we
Coherence.
Maybe we can talk a little bit about what this looks like more concretely in a kind of typical therapy situation.
Good. Perfect. Thank you. So, and now, so far, by the way, my Modes of Therapeutic Action book, written back in the 1990s, is what I'm saying now. It's in keeping with what I was saying then, but it's a little more elaborated, a little more refined. Is that your sense? Because I haven't read the book recently, and so
that is my sense. I think Modes of Therapeutic Action is really like, it sticks to, it's less abstract, and it's talking about really concrete examples in therapy. And what you're talking about are these really higher level principles, I think, which almost
that's right.
bind it together. But maybe we could talk a bit more concretely.
Well, so let's talk more concretely. So my book, it was originally called Models of Therapeutic Action. And the copy editor, I think unconsciously didn't like the word model. So they just dropped the L and made it Modes of Therapeutic Action. And I didn't even notice it until it was already printed. But it was better as modes. So I was grateful. So Modes of Therapeutic Action. So I just want to go over the title, which says a lot. Modes of Therapeutic Action, enhancement of knowledge or insight within. So these prepositions are going to be important. Within. That I'm going to be calling Model 1, the interpretive perspective of classical psychoanalysis. That's Model 1. And there's going to be 2 and 3 now. Model 2, provision of experience for, preposition for. And this is the corrective provision or deficiency compensation perspective of self-psychology and other deficit theories. And Model 3 is an engagement in relationship with. And this is the intersubjective perspective of contemporary relational theory. Now I'm going to, these 3 modes are interdependent. It's not like you do only one. In fact, in an individual session with a patient, no matter what their diagnosis, this is not based on diagnosis. It's based on where they are in the moment, whether your sense is, so the point of emotional urgency for the patient. If in the moment, model 1, they seem to be neurotically conflicted. So we'll just say structural conflict, jammed up, stuck. Then you know that you're going to want to help advance them. Together you work to advance them from resistance.
Could you give an example of a typical neurotic conflict?
Yes. So they can't finish their dissertation. They just can't. And they're stuck. And as a result of enhancement of knowledge, as you work with them, so model 1 involves interpreting. It's a little more cognitive. Model 2 is going to be more affective. Model 3 more relational. But back to model 1. So they're jammed up. They can't get the dissertation done. We work with them. We work through their resistance, which is the defense, to doing what they know they would want to be doing, but just for some reason can't. And ultimately, they become aware of the fact that deep down inside, they have always yearned to be able to have their father approve of what they do and think that they're really quite wonderful. And they're kind of jammed up around that, and they're afraid their father's not going to think it's good enough. And they're concerned that it won't be good enough. And so they're jammed up.
So they have a fear of failure, which prevents them from...
Fear of failure, and that it won't be good enough. And they learn that by way of you work with them together, you work to interpret. And again, you're not going to get it all done in a heartbeat, but this will come up periodically, because again, moment by moment over the course of a 45 or 50-minute session, all sorts of things are happening. But in that moment, they're jammed up and they advance from the defense of resistance. And it's going to be relevant that the defense starts with the letter R. We'll see why in a moment. But anyway, from resistance to knowing about the internal forces within, to awareness or insight. I'm going to say awareness because the adaptations start with the letter A for ease of remembering. So in essence, they become aware of the fact, and in becoming aware of it, it will free them up, hopefully enough, they can, by golly, have a choice and take more ownership then, and then move forward with their completing their dissertation. Put simplistically, but in essence. So that would be 1. So model 1, just a little more cognitive and about interpreting.
So model 1 is about self-awareness.
It's about self-awareness. It's about self-awareness, exactly. Model 2, the corrective provision or deficiency compensation model of self-psychology, and patients who have it's called, these are big words, but structural deficit or impaired capacity. So whereas model 1, which we just talked about, is structural conflict, as Freud said, or neurotic conflict or intrapsychic conflict, and advancing to self-awareness, as Alex said just there. In model 2, now we're going to be talking not so much, we won't be privileging, that's such an ostentatious word, but anyway, we won't be privileging interpretation, but rather grieving and experience. The therapeutic action will involve grieving. Let's see if I can put my money where my mouth is here. Because early on, there were certain, they're called self-object functions, but let's just say parenting functions, psychological functions, because those weren't provided consistently and reliably early on for the patient. It might well be that the patient, in addition to having structural conflicts and being jammed up around stuff, has structural deficits or impaired capacity to be a good parent unto themselves. And they
might have lacked good consistent parents, and so we internalize our parents. So if you don't have good consistent parents, you can't be a good parent to yourself. And funnily enough, we do need to parent ourselves to get on in life.
There you go. And so the deficit, because we didn't get, as you said, the consistent, reliable, good parenting, the deficit, structural deficit, impaired capacity to be a good parent unto yourself, the deficit creates the need. The need is for the objects in the here and now. The transference object, the therapist, contemporary objects, your friends and colleagues in the here and now, and belatedly, the infantile objects, because you're still hoping. The deficit creates the need for environmental, as Winnicott called it, environmental provision in the here and now. So you go into relationships filled with need for your objects. We call them objects. They're people, but we call them objects or self-objects, to provide for you in the way that the parent should have, but didn't consistently and reliably. So in the treatment, if all goes well, the patient will deliver their need into the transference, and they'll come to hope that the therapist will provide for them in a way that was not consistently, reliably provided early on. Now, where does grieving come in? Some psychologists believe, fair enough, that it's just the patient's experience of being met and being held by a good therapist will be healing. But I know that for myself, in my work with my patients, I can be loving, empathically attuned, authentically engaged, and all the good stuff, but the deficits are still there. There's no real deep and enduring structural, psychodynamic, characterological change. Rather, this is where optimal stress comes in. Rather, it will be in the aftermath of the periodic empathic failures on the part of the therapist that there will then be impetus and opportunity for there to be a grieving of those by the patient. All right, now, how is it that grieving is such a cool thing? Well, it is. And this you don't try to explain to a patient, because if you try to, as I have on occasion, you will make a fool of yourself. So, but I'll just explain conceptually what it is, but it's very powerful. In grieving, the patient will, they're upset, they cry, they're angry, they grieve your failure of them, the empathic failure, the disappointment. And part and parcel of the grieving will be an adaptive, important word, adaptive, right? Like adaptation, an adaptive internalizing of those functions that they had been providing prior to the empathic failure, and that they are providing now as you're grieving and trying to work through your heartbreak and your disappointment. And those are called, big words here, but you get the concept, adaptive transmuting, meaning structure building, capacity enhancing internalizations, such that you fill in deficit and consolidate the self. And it's done by way of grieving. Now, I can actually give an example.
Maybe could I yes. break down what you just said and make sure I've understood it correctly? So as opposed to mode 1, which is more about enhancing kind of self-awareness in a kind of cognitive way.
And a little more cognitive.
Yeah. Mode 2 is anticipating that the patient has some kind of deficits, and let's say that's consistent parenting, maybe you could call it love, you could call it empathy, all of those things. As the therapist, you're yes. providing those things because they're in deficit, yes. but mere provision of those things doesn't fill the deficit in any long term.
Often does not.
In my experience, it can, in the short term, but as you point out, and it's not necessarily a good medium to long term strategy. But what happens is, because the therapist is human, they inevitably fail at some point. And when they fail, that's a window of opportunity for them to grieve not only the failure in that instance, but the deficit itself. And then the reparative process therapist and client can engage in cause that
an opportunity to grieve belatedly
the parental failures. Yes. So it's a window of opportunity to grieve, and of course grieving is a healing process. It's a process of letting go, I guess, in some sense.
Yes. So here's a good example. Now, this is an old-fashioned example, but I hope it will work here. So there's mommy, and it could have been the daddy, but in the moment, let's say it's the mommy. So the mommy has her little baby in her arms, and she's rocking the little baby, and little baby's very happy, and it's all good. But then, by golly, because she doesn't have a cell phone, because this is from a long time ago, she doesn't have a cell phone. The phone on the wall in the kitchen rings. So she puts the little baby down in the crib and she rushes to the phone, annoyed because she didn't want to have to do this, but she wants to answer the phone. So she's on the phone. The little baby is really upset and crying and angry and upset and scared and terrified, whatever. But mommy finishes up real quick, like comes back, picks up the little one and rocks the little one. And in a short period, the little one is sort of calmed and soothed, and it's all good, But then, by golly, the phone rings again. So the mother goes, and the little one is like really crying and upset and angry and scared and frightened. But, and this is, by the way, going to happen series of cycles, that's going to happen a number of times. After a while, the little one kind of gets it in a sort of wisdom of the body sense that though mommy was gone, mommy comes back. So there's the experience of gone, but recovery. And so has a little bit adaptively internalized the concept of gone, but comes back. And so that's the way in which we and the patients, and we period in our little babies, they adaptively internalize good stuff. If it's there all the time, there's no impetus or opportunity for it to be internalized. But if periodically it goes away, then you want to preserve internally a piece of the external experience of goodness. So adaptively, you internalize it. And parenthetically, in the literature, and this will become relevant in Model 3, when you take in bad, like a pathogenic introject, it's called introjection in the psychoanalytic literature. When you take in good, it's called internalization, like transmuting internalizations. So Model 2 then, whereas Model 1 is about a little more cognitive, about interpreting and advancing the patient through healing cycles from resistance to awareness about the self and the self's dysfunctional dynamics. Model 2 is about advancing the patient from relentless pursuit of the unattainable. Like you can't ever have the ideal mother, parent, father you could have, should have had early on, at least consistently, reliably. You can't.
You can't go back in time.
You can't go back. You can't go home again.
And isn't it the case that when people have such deficits, they often fall into relationships that repeat that kind of dynamic that they would have had with their parents?
Yes. And the audience can't see this, but I am nodding my head vigorously. That's absolutely right. And that will also segue us in a moment into Model 3. But so in Model 2, then, yes, from relentless pursuit of the unattainable from the object, or relentless hope that the object will be the ideal parent one didn't have reliably and consistently early on. Or maybe even just the good parent one didn't have consistently, reliably early on. But now I'm going to ask the audience to kind of think of the answer here. Advance the patient from relentless hope, relentless pursuit of that which can never be. The panel of 10,000 judges would say, forget it, it's not going to happen. 2, by way of healing cycles of disruption repair, which is what the grieving process is all about. Advance the patient to an adaptation that starts with the letter A. So from relentless hope to sober, mature acceptance, where you accept the reality of the object as being imperfect, separate, and immutable. That nice word, immutable, like can't be changed. You can't force the objects in your world to be what you would want them to be. Of course, you are relentless in your pursuit and insistent that they change so that they will fill in your deficits. So that's Model 2.
It's interesting because
Now, yes,
unrealistic, relentless hope doesn't just come into play in romantic relationships, but people who are possessed by it, it can come into play in their career, in their friendships, in their familiar relationships, in their whole interaction with the world can be one of this ongoing cyclical narrative of, I try my best and I try and try and try, but I fail.
right. That's exactly right. That you keep trying to win your boss over, or you keep trying to, get your neighbor to something or your children to something. And again, the panel of 10,000 judges would say, it's not going to happen. So if in the moment in the session, the patient is caught up in, now, one, they might be in the moment, jammed up, neurotically conflicted, model 1. In model 2, they might be narcissistically needing the object to be a certain something to fill in for deficits. And they tell you these stories. They want their mother to apologize. They say, I know my mother's never going to change, but I just want her to apologize. The panel of 10,000 judges knows that the patient is now 40, the mother is 70. Has the mother ever apologized? No. So it's not likely. So ultimately, the patient needs to confront the reality of the object's limitations, separateness, and immutability, and needs to grieve that, and in the process adaptively internalize the good things that the mother did do, the good things that the therapist is doing, has done, is doing,
and the good things that the person could get from elsewhere.
Yeah, yes, and that you can be a good parent unto yourself. So whereas model 1 more cognitive, model 2 more affective, and certainly words are used and so on, and statements and so on, but it's about grieving. And I can go on to model 3, but then I'm also willing to come back to offer a prototypical disillusionment statement from model 2 to facilitate the grieving, and a prototypical conflict statement from model 1 to facilitate resolution of conflict. But let me share with you, if I could, model 3. So now we have the intersubjective perspective of contemporary relational theory. Now we have the defense here. So whereas model 2 is about, remember deficit, is about good stuff that didn't get in, creating deficit, model 3 is about bad stuff that did get in, pathogenic introjects, internal bad objects, dysfunctional relational configurations.
Could you give me examples of those, or one of them?
You were abused as a kid, so you didn't get love. So model 2, you have an impaired capacity to self-love, but you did introject the pair of abuser, abusee, victimizer, victim, that their dysfunctional relational dynamic. You weren't able to process and integrate it and adapt. But no, you introjected like a bolus of toxicity, this pair, this dynamic of victimizer, victim. And now inside of you, you have victimizer, victim, which you will often play out internally. And so you're busy punishing yourself, and you're busy, shooting yourself in the foot, et cetera, et cetera. In model 3, the intersubjective perspective, in a way, we are inviting the patient to deliver their dysfunction, if you will, but the pathogenic introjects, to deliver those into the relationship with us, which becomes, by the way, a negative transference. But we want that to happen so that, now, why would we want that? Well, one, it enables us to gain access to what would otherwise have remained an internal something. And the patient just hates themselves, and they say, I just hate myself, and I did this, and I failed again. I hate myself. I hate myself. We want them, we invite them in a way, if they feel safe enough, that they can play out, they can compulsively and unwittingly reenact or play out their unmastered early on relational traumas. They can play them out in the treatment with you.
So they might project the persecutor onto you, the abuser onto you.
That's exactly right. They might project, indeed, their experience since they early on they were ever busy being victimized. You're exactly right, Alex. They project onto you, the persecutor, you the victimizer. Now they can actually also go a little further. And in model 3, which is a 2-person something, which is a story about mutuality of impact. It's a relational, intersubjective perspective. Now, not only do they project it onto you and experience you as an abuser or critical or what have you, but they act in such a way as to get you to become it. I'll give you an example.
Which is what we call projective identification.
And which is called projective identification. Yeah. Where you actually do involve the other person in the what you're compulsively and unwittingly reenacting. But the good news, and I'll give you an example in a second. The good news in that is that it offers impetus and opportunity for the therapist to lend aspects of her own more evolved capacity to process and integrate on behalf of a patient who truly doesn't know how. So though initially, as part of the projective identification, the therapist will be drawn in to participating and will become a little bit critical, maybe be a little bit abusive, be kind of judgmental. So that's the induction phase. And the therapist does indeed get caught up in a transference, counter-transference entanglement, and it becomes a co-created impasse or co-created therapeutic impasse, whatever. Ultimately, the therapist needs to be able to step back from her participation in this mutual enactment, needs to recover thereby her therapeutic effectiveness so that she can lend her own capacity to a processing of this charged toxic bolus that came into her, as such that then what goes back to the patient in the resolution phase of a projective identification is what Winnicott referred to as an amalgam. Part the original charged toxic, but now slightly modified. And that's what goes on.
And what does that look like? What's the therapist doing or saying to produce that result?
So the patient comes in and the patient says, she's a young gal, and she comes in and she says, I went out to a bar last night and I had a really good time, but I drank a whole lot and I met a guy and, I sort of liked him, whatever. And I went back to his place and we just had sex, it wasn't protected sex or anything and whatever, but we just had sex. And then the patient pauses and says, now I'm guessing you're critical. You're feeling critical. Well, maybe a little critical. And now, and so rather than now we're professional enough that as we're listening, we don't say like, oh my God, that's horrible. You could have gotten pregnant or sexually transmitted disease. But inside of us, admittedly, and they knew it. I mean, we're not, whatever, they know. And so what we ultimately do is we negotiate at Darlene Ehrenberg's intimate edge, negotiate in the relationship here. What we get to, and it's hard to describe which sentence got said, but ultimately the patient comes to appreciate that, yes, though admittedly the therapist did feel critical, did become judgmental in that moment, the patient comes to understand her contribution to what happens for her in her relationships.
She comes to understand that she's an active part in producing that dynamic.
Yes. It's about the patient's sense of agency. You're exactly right. Her contribution, her participation in this.
But also, does the therapy, is there not also a process going on whereby the therapist communicates that, yes, I might have judged you in that moment, yes, I'm human, I might have gotten angry, but they also communicate that there's a foundation of love and care, and that rupture and anger and fights can exist within a cocoon, if you like, of basic love and care. And so
yes,
anger,
both. Yes,
mistakes, judgments, they stop being existential threats to the relationship, and they can be something containable within a greater productive relationship.
That is exactly right. And Winnicott talks about the subjective and the objective countertransference. And the objective countertransference is sort of like what any therapist, any human being would feel listening to a particular story. The subjective countertransference might well be some extra something that the therapist contributed. I'll tell you, so in Model 3, part of what's sort of interesting about it is now the therapist really does bring her subjectivity. It's an intersubjective perspective and her subjectivity into the room. I actually had a real kind of, Paul Russell would call it a crunch situation, but anyway, a therapeutic impasse type thing, where the patient, who is not disabled at all, will park her car in disabled parking spots. Now, I've talk to colleagues and friends about this, and they say, oh, yeah, you shouldn't do that. But for me, I really don't like that. So that's a
so
counter-transferential
personal
thing.
to Martha Stark. It's a pet peeve
Personal
of yours.
to Martha Stark. I don't like it. And though I didn't, when she tells me she does it, I don't say like, oh my God, you're just a horrible person. It was clear, obviously. I had the capacity to know that I was defensive reacting, and the integrity to acknowledge to her. And we had to negotiate at our intimate edge. And we both acknowledged our contribution and recognized this, that, whatever. But we, as a result of that negotiating at our intimate edge, it deepened our relationship. And also she came to understand that in numbers of ways in her relationships, not necessarily around parking in disabled parking spots, but that she can be sometimes provocative. And that because she would said it on a number of occasions about the parking and the entitlement that she had, or like going to the Whole Foods, and there was a bouquet of 12 roses, but one of them she didn't like. So she would discreetly put it into another bunch and bring a better rose and put it back into her bunch. The same kind of, from my point of view, entitlement that would drive me wild. Wouldn't necessarily drive someone else wild, drove me wild. But in any event, as we worked that through, I acknowledged and took ownership and so on and so on. And she came to understand that she gets provocative interpersonally. And that's an important realization for her. And she knew how to push my button. But anyway, so that's negotiating at the intimate edge. So whereas Model 1, a little more cognitive about interpreting, Model 2, a little more affective about grieving and also providing a nice holding environment. And Model 3 is a little more about negotiating at the intimate edge. So as you sit with the patient in the moment, if they're playing out something on the stage of their life, on the outside with you, with their parents, whatever, you think Model 3. And negotiating. If they are just really hoping that their boss will give them a raise or whatever, or that their child will acknowledge you think Model 2. Or if they're kind of jammed up, whatever, you think Model 1. And these are interdependent, mutually enhancing modes of therapeutic action. And in Model 3, we would say finally, so where's Model 1 from resistance, the defense, to awareness or insight, the adaptation. Model 2 from relentless hope, the defense, to acceptance, the adaptation. In Model 3, from reenactment of unmastered early on relational traumas, to accountability.
Responsibility.
Where you take ownership, you hold yourself responsible, and you get it. It's not that you're never going to act anything out, but that you get it, that you tend to be a little provocative, or you tend to be a little passive aggressive, or whatever. And the combination of awareness, acceptance, accountability can take the person pretty far.
Absolutely fascinating. We've talked a little bit about victimization as a defense, and a lot of psychologists have proffered that we're seeing this acted out a lot in our culture, that victimization has become very, very prominent in our culture, in our politics, on the internet. Would you agree with that notion?
Heartbreakingly, yes. It's, I mean, COVID and all, whatever, but just everywhere around the world, just in the internet and the social media, that this is just being, and people can do it sort of anonymously, the acting out of the sexuality and aggression, Freud's two, libido and aggression, and it's just heartbreak. So it gets played out on the world stage, and when there's not enough containment of it, and there's not enough, then it can just go. And I think we're all, interesting for me to be hearing you over there in London and the UK, and me here in the US. It's everywhere. From the drivers to, I don't know if you have as many shootings as we do, but just, people with the guns and just shootings and stuff, and just go kill people and go this and that and run their car through crowds. I don't know, maybe 100 years ago, people did the equivalent to that, but it sure seems as if it's just gotten out of control. And it's very disturbing. All the unresolved, unmastered, early on relational traumas. So I would have wanted to say so in model 2, which is about deprivation and neglect, not getting enough love. So deprivation and neglect, absence of good. Model 3, more about presence of bad, more about trauma and abuse. And so our childhoods, to the extent that they kind of can mess you up quite a bit, if they don't get corrected for, then these dynamics, dysfunctional ones, will be played out on the stage of the world.
And you start to see humanity as almost like a macroorganism.
Oh yeah. And it expands from the small to the all, from the little microcosm to the macrocosm. I had promised, and I don't know if it's important that I do it, but that I have a prototypical kind of intervention that clinicians can use in model 1, 2, and 3. Should I do that, or do we want to go on to what you were going to say?
I think that would be good.
I'll mention it quickly. Okay. So model 1, where neurotic conflict is center stage, I have suggested a conflict statement, because my students are always saying, well, can you give me an example of what you would say? So, a conflict statement. It's very easy. Here's the prototype. You go to the patient, you say, you know that. And there you're speaking to their adaptive capacity to know something. You know that. If you keep smoking, eventually you will get cancer. If you continue to be provocative like this, you're going to push people away. You name the thing that they really do know. You do know that your mother will probably never really apologize. The thing that they really do know. You can't cheat. You can't say something they don't know. Or you can say, that until you get a handle on all of what went wrong early on, you're going to be playing that out in your life in the here and now. And they have to. They don't like it. It increases their anxiety. It's a stressor. They're not loving it that you say it, but they do know it. And notice that you're saying, you know that. Those are 3 really special words. Not, if you keep smoking, you're going to get cancer. You know that if you keep smoking, and they do, then there's an imagined comma, but you find yourself, and now we resonate with their defense. You find yourself thinking, but wait a minute, smoking is the only thing I do that gives me any kind of relief. Or, but I just feel that I can't go on until my mother does apologize. So you resonate empathically, you support. So first you challenge, you know that, and then you support.
So in the case of the dissertation, it might be, that you need to finish your dissertation, yet you find yourself paralyzed.
And that you probably need to figure out what it is that's getting in the way of you doing that something's jamming you up, and that probably something about early on, the relationship you've talked about with your father, that probably we need to go back to revisit that in some way. And they're like, yeah, okay, comma. But in the moment, what you're thinking is, by golly, you'd like to be able to just move forward without having to get back into any of that. That was long ago. Who wants to deal with that? No. So you get both sides of their conflictedness, ambivalence named. So thank you. That's exactly right. Okay. Model 2, disillusionment statements. Now this one, it has 3 parts, but bear with me here, because I think it'll make intuitive sense. Now we say, in the first part of the disillusionment statement, we say, you had so hoped that your mother would eventually apologize. I'm putting in the past perfect or pluperfect tense. You had so hoped that your mother would apologize. But, that conjunction, but, you are beginning to realize that probably she won't ever, never has. Third part starts with and, the conjunction and it breaks your heart. It angers you. It devastates you. It upsets you terribly. So let me say it again. You had so hoped that I would give you those kinds of answers, but you're beginning to realize that I really don't, that I tend to say these are answers that need to come from within you. And it really upsets you that it works that way. And it angers you. So that's to facilitate their coming to terms with some disillusioning, painful realities that they so wish weren't. You're helping them to evolve to a place of acceptance. Mm-hmm. Does that make sense, Alex?
Absolutely.
Okay, and in model 3, it's a little harder, but I'll give you an example of an accountability statement, because this is so in the moment, back and forth mutuality of influence and impact. So model 3, I have something called the rule of 3, and I think this might be helpful for clinicians out there listening here. It's simple. 3 questions, 1, 2, or 3 you can ask. When a patient does something that's provocative, interpersonally, intersubjectively, you can ask 1, 2, or 3 of the following questions. How would you like me to respond to that? That's more about id. 2, how are you afraid I might respond to that? That's more superego. 3, how do you imagine that I will respond to that? Which is more about the dorsolateral prefrontal cortex of the brain, but the executive functioning of the brain. The ego. How do you imagine that I will respond?
So the id is about desire. The superego is about anxiety and what fear. Mm-hmm. And the ego is about reality or reality anticipation.
Yep. Those are exactly the words. That's exactly right. So I get to the end of a session and we're at the door with a patient I've been seeing every week for a long time, each week, whatever. At the door, she says, oh, by the way, I think I'm going to take a break for a while. Now that I call a provocative enactment. So when they play out something and that you experience as sort of like it throws you off, provocative, whatever. So in the moment, I panicked a little bit inside, and then I remembered my rule of 3. And I said to her, how do you imagine I'm going to react to that? I figured I'd get a little supervision from her. How do you imagine I'm going to react to that, said I. She paused and said, oh, she'll probably say, we'll talk about it next time. And I said, yes, we'll talk about it next time. She did come back next time. We did talk about it. She didn't take a break. So that's the rule of 3, and it speaks to the dynamic. It's an example of a relational intervention, speaks to the dynamic.
So which one you tend to use the reality-oriented one?
Any one of the 3 would have had to do.
Any one of the 3 would be informative of something.
And making her put into words, and she might say, well, I guess I was hoping that you would hug me. Not in that case, but, or I guess I was afraid you would punish me. Whatever she says is going to be very telling. Or I was trying to, instead of her enacting it and reenacting an unmastered provocative something from before, I rather than her just doing it to me, there's another example of, this was one of my supervisees. The patient at the very end says to the therapist who had just come back from a week of vacation in Florida, the patient says, great tan bitch, as she's leaving. The therapist, a little bit like, oh my God, I just said, see you next time. But between times, she was able to think about it. She presented it to me in supervision, whatever. And we had her at the beginning of the next session. This isn't the rule of 3, but this is an example of an accountability statement or a relational intervention. At the beginning of the next session, the therapist said, you've talked a lot. We've done a tremendous amount of work in here about this. But you've talked a lot about how you just don't understand why you don't have women friends. At the end of last time, you said, great tan bitch. I wonder if that was your way of showing us what happens for you when you get close to someone and start to feel competitive. And the patient like, oh my God, yes. So there, the therapist see how that used the relationship there to inform an intervention. And again, it's not about we can't ever disturb the patient. We need to be able to leverage their anxiety and be okay, since we do optimally stressful things, just the right balance. We need to be okay with leveraging their anxiety such that sometimes we increase it, sometimes we decrease it. But the thought being that if we do that consistently and judiciously, ultimately we will advance them from defense, whether it's resistance, relentless hope, or reenactment, to adaptation, more awareness, more acceptance, and more accountability.
And is your dichotomy of defense and adaptation, is it similar to Maslow's deficiency versus actualizing?
I only just kind of knew about his pyramid, right?
Maslow has a book called On the Psychology.
I think it has the word self-actualization in it even.
But he has a book called On the Psychology of Being, which is fantastic. And in that book, he delineates the difference between someone in a deficiency mode of living and an actualizing mode of living. So a deficiency mode, like a deficiency mode, might be working a 9-to-5 job you hate. I'm sure everyone can relate to that. And an actualizing is starting your own business. You know, it's coping versus thriving. It's defensive versus proactive.
Well, actually, I promise I'll say this real quick. Since the 1990s, I have added Model 4 and Model 5. And Model 5 is about advancing the patient from, and again, the defense has to start with the letter R. So refractory inertia, or rootedness to the spot, or rot, when somebody has awareness, acceptance, accountability, and Model 4, which I haven't explained yet, but accessibility. But they're stuck. They're rooted to the spot. So Model 5 is for analysis paralysis. And we want to get them, it's a quantum neuroscientific approach to getting them helping them with their stuckness and non-action, and advancing them, getting them unstuck, quantumly disentangled from the toxicity and deficiencies of the past, and into a more action mode. Just do it. So actualizing action. There's the A word.
Why is it quantum or neuroscientific?
So the neuroscientific piece has to do with, and by the way, these 5 modes, each decade of my professional development, as I've been exposed to new stuff, then I have to add a model so that I can keep myself current.
So the models are your way of understanding new information that you encounter in the therapy world.
Yes, that's a beautiful way to put it. Yes, thank you. That's right. My way of understanding it and wanting to sort of pass that along to other generations are my legacy. So the 70s, I was learning the classical psychoanalytic, very conservative training at the Boston Psychoanalytic. In the 80s, I was being exposed to self-psychology and Michael Ballant and all that good stuff. The 90s, all the interpersonal, intersubjective folks, Owen Rennick and Stephen Mitchell and Jay Greenberg and Darlene Ehrenberg, all that. Then that decade, I never remember the name of it, but 2000 to 2010, their decade, that's a more existential humanistic approach to mending brokenness and easing relentless despair. And we want to advance the patient from relational absence. And now we have the private self, Winnicott's private self, a heart shattered, the private self, and a life unlived, to authentic presence. There's the A word, authentic presence. All right, but Model 5...
The idea of the life unlived is haunting. I think that I was reading Love's Executioner by Irving Yalom, and he talked about how, in his experience, the amount of anxiety one has about death is proportionate to the amount of potential they think is unfulfilled, of their life's potential.
In their lives. I love it. I mean, the existential humanistic in you is just lovely. I love that. It just permeates all of your cells, and I love that.
That's good to know.
So yeah, totally. So authentic presence. And in Model 5, yes, from rootedness to the spot. Okay. So It was in this decade of 2010 to 2020 that I immersed myself in some of the short-term intensive treatments and got some training in them as well. So ACT and NLP and AEDP and ISTDP and IFS and somatic experiencing and psychomotor psychotherapy. Anyway, these short-term intensive folks, they do and know a certain something that the longer-term in-depth folks weren't really onto. And I wanted to be flexible, always good to be flexible. And so I incorporated what I was learning from them into what then became my fifth model. So model 5 features therapeutic memory reconsolidation, which is a brain-based something, which I think is at the heart of some of these short-term intensive approaches. As I conceptualize it, it involves therapeutic memory reconsolidation. It's more brain-based, and it involves a sudden, dramatic, and forceful juxtaposition of old bad narratives, rigid defenses, same old ways of being and doing, with new good, envisioned possibilities of something new, different, and better. And you juxtapose old, bad, new good, old, bad, new good, old, bad, new good. So you destabilize, and then you create, there's a reconsolidation window where if you enough of old, bad, and you then introduce the envisioned possibility of something new, different, and better, and in that reconsolidation window of opportunity, then you have a chance of eradicating, say, Bruce Ecker and David Feinstein, eradicating the old bad, and in its place, putting in new good. So in model 5, which is about quantum disentanglement from the old bad by way of forcefully, intentionally and judiciously, and repeatedly introducing the envisioned possibility of new good, old bad, new good, old bad, new good. You can, it's a little more aggressive, these short-term intensive folks, they're a little more aggressive. Yes. And quite frankly, really sometimes profoundly successful. So, and the quantum piece has to do with the idea that when you envision the future, there are infinite possibilities, and you can, so that instead of models 1 to 4, which focus on the relationship between the past and the present, and how the past is being ever busy, played out in the present unless you're careful, model 5 focuses on the relationship between the present and the future, and that you can create your future. And so the name of the book that I'd written, I guess my most recent book, that's right, although I'm working on another one now, The Art and the Science of Interpretation. But the one that's published, the most recent, is, the name of the book says it all, from Soren Kierkegaard, Understanding Life Backward, but Living It Forward, : that's Soren Kierkegaard, I copied from him. Then you go, Analyzing to Understand, models 1 to 4, analyzing to understand, but envisioning possibilities to incentivize action. Or we might want to say, a la Maslow, a la Alex, to incentivize self-actualizing action.
Doesn't model 4 have a future perspective as well because of its, or not
it
so
does.
much?
It does, but it's not as aggressive. So in model 5, So in model 4, thank you, So model 4, an existential humanistic approach to mending brokenness and easing existential angst. This is about going from, I'm going to say it in 2 ways, and I think you'll really like both of them. So the first one, I'm repeating, from relational absence. So this is schizoid retreat and psychic shutdown and gun trip and the schizoid retreat and so on. Some relational absence to authentic presence. That's the more humanistic part of it. But the existential piece is nihilistic rejection. There's the R word of existence. To existential acceptance of its dualities, polarities, complementarities.
Tell me what are the polarities?
That a part of living is death. That complementary its existence and just evolving to a place of, so it is true that yes, going forward is your responsibility. You can't control what had been, but going forward, it's for you to make of your life as you will. Not only is it, an option, but it's sort of your responsibility. Not only do you have the freedom to do it, but sort of the responsibility to do it. But it's again more gentle. And the in model 4, the therapeutic action. So whereas model 1 is interpreting, model 2 grieving, model 3 negotiating the intimate. Model 4 is about surrendering. And now I'm lifting from Masood Khan, and I go, model 4 is about facilitating the patient's overcoming of her dread about becoming resourcelessly dependent upon another, on life. So you've helped the patient overcome their dread of resourceless dependence or absolute dependence, that's Winnicott, or existential dependence, which means the very same thing, on another.
Or even or even the dread of existential aloneness, because
yes. And so I hear Michael Balint talks about helping the patient experience a blissful state of peaceful merger, and then there's an Israeli analyst who talks about analytic oneness. So model 4 is the soft, gentle, tender, where you become the devoted mother, where you, Winnicott called it that, devoted parent. You become
where you choose life in the face of death.
Yes, goddamn, yes. I hope you don't have to get rid of that word, goddamn, but whatever.
No.
You choose life in the face of death, yes, but ever aware that there is death, but evolving to a place of existential acceptance of its dualities. So it's much more about just a calm, quiet acceptance, sober acceptance of existential realities and I love model 4, quite frankly, myself.
And I think it's also interesting in terms of our broader society, because I think we, up until recently, had a number of, really it was major religious institutions, but then to a lesser degree, I think political institutions, which kind of provided an existential containment. But I feel like at the moment, the religious institutions,
we don't have that.
Certainly they're decaying. And so similarly, the political institutions, we're seeing an unraveling of faith in institutions, and I think that's causing there's a upspike in existential
crisis.
Yeah.
Thank you. I hadn't thought of that at all. And I love that. That captures it beautifully. Right. We don't have any kind of containment.
Wow.
It's just out of control.
So we have to provide our own containment in the face of freedom.
Right. And then if you're not careful, you get COVID and die anyway. It's just scary what we're living with. It's surprising to me in a way that we even walk around without just screaming in terror. Because it's just scary what we're in. The political environment, and then you've got your political over there. It's a scary. And yet we have to keep living. We have to go on because this is it. And then in 10 years, 50 years, 70 years, that's it. We're gone. And we just try to do the best we can. It really is about existential acceptance of the dualities, polarities, and complementarities of existence, of life, that we live life, but against the backdrop of knowing its finitude and that death is always, Camus and them others, Heidegger and Sartre, of course, love them.
And also, I think in the West, we have a complicated relationship with freedom in that we explicitly, overtly on the surface, want freedom and will do anything to get it. And yet I feel unconsciously we realize how terrifying it truly is.
Oh, yes. And what a heavy responsibility it is. Oh, my God, that is great. Yeah. We're torn. It's hard.
Because I see it in my generation, because in my generation, a lot of the attitudes of the zeitgeist seem to be ultimately motivated by the freedom to do anything and be anything at any time. But when that's enacted, it's kind of dysfunctional, because ultimate freedom is
chaotic. It's not coherent.
It's too chaotic. It's kind of not achievable, and it's also, aside from not being achievable, it's in the pursuit of its achievement, it's quite dysfunctional.
Yeah. And then all this stuff, I mean, on social media and all the ugly stuff that comes out. On the one hand, it's great that we can say anything we want on social media. And on the other hand, well, maybe not. I mean, that stuff that's said is just terrible. And so maybe there should be a lid and sort of like, what do we do? And yes, that's right. Yeah, this is good. It's sobering. and we can be overwhelmed with despair, right? So we just have, and that's why the name of my book that's about Model 4 is A Heart Shattered, from early on stuff, family of origin stuff, A Heart Shattered, The Private Self, and A Life Unlived, an existential humanistic approach to existential angst. And we all have it, and we all are going to die at the end, and while we're living, people close to us die. And there's just this stuff around us that's ugly, and the violence. And I mean, really, it's...
And yet you could also argue it's some of the best times to be alive in human history.
Arguably. Well, okay.
Maybe we disagree.
Maybe I haven't evolved yet enough to existential acceptance of, but maybe that we have more now. I mean, if somebody said to me, well, how about this, Alex? Would you wish you had lived 100 years ago? No, I want to live now.
Yeah,
so there's the answer. I'm glad. I want to live now.
And maybe I could, because I was going to ask, what are some of the practical solutions against existential dread? And you come across to me as a very happy, driven, motivated person. And it seems to me, in part, the meaningful pursuit of things you care about contribute to that. And do you agree with that? Or what has it been for you that's motivated you?
Thank you. I just wrote that down. I just love what you're saying here. I would like to say that this is where I'd said earlier that in any adaptation, there's a defensive component. And I get tremendous joy from writing and from thinking. I mean, I spent decades having a very, very heavy caseload with patients and consulting and supervising, and I like decades and so on. And now as I've gotten older, I've cleared away more time to do my writing. And I love writing. I love creating PowerPoints. But it is clear to me that there is, it's okay, but a defensive component in it, so that I don't have to be quite as having death and the absurdity of everything around me and the violence in my face, because I can just sit down and I can have a lovely conversation with you. I can just work on my PowerPoint slides and so that I don't have to be fully immersed in it. So yeah, that's really good. So that there's a defensive component, but that's okay. I'm not judging that, but just naming it, by the way, it protects me.
There's nothing wrong with a defense unless it's causing you problems.
Nothing wrong with the defense of something, right? As long as, right, there's also something, right, adaptive and very adaptive and pleasurable and enjoyable. Yeah, but that's interesting. What do you do? I mean, of course, you're heavily involved in your studies.
Yeah, I would echo something similar that I feel, well, I would kind of echo Yalom's thoughts in that as long as I feel that I am doing my best to live out my potential, I don't feel very anxious about, like, I feel like if I had to get an aneurysm and go just like that, I would have a kind of a bedrock satisfaction that I gave it my best shot.
Yes. Oh God, that is so good. I totally get that. That you are, yes, you're living out, and that's why self-actualizing is so important to you and to me as well. That to this point in time, you have done your damn best to be as self-actualized and fulfilled in how you're living as possible. Obviously, you don't want to drop dead from an aneurysm right now, but if you did, whatever. Sometimes
for me, the pain would be regretting not trying.
Yeah, that's right.
Which is what people, as far as I know, that's what people generally tend to report in near-death situations. It's not
what they did.
It's not having failed. It's
right
it's
at
having,
what they tried to do, but the things they left untried.
Yeah.
There have been occasions, and these are really very special sort of peak moments. Certainly, well, in lovemaking, tender, passionate lovemaking, but also like I dance a lot, and so although with COVID it's been a little trickier, but anyway, dance a lot, and there have been occasions when I am dancing. It's partner stuff, West Coast swing. I don't even know if you guys over there know what West Coast swing is, but anyway, West Coast swing. Anyway, and you're dancing and the lights are down and you're listening to the music. Maybe it's Backstreet Boys, maybe it's Bruno Mars, maybe it's Michael Jackson, and you're dancing and you're so connected with your partner, with yourself, with the ground, with everyone around you. And these are just peak moments where literally, if you died in that moment, whatever, not a problem. It's so precious. Those moments are very precious.
Absolutely. And what a wonderful note to end on. Dr. Stark, this has been absolutely amazing. I enjoyed picking your brain so much.
And I love this interview with you. You are really priceless. You are wonderful.
Thank you so much.
Alex.
I'll make sure that I can direct read this to some of your work in the description so they can find you. And definitely love to have you back on in the future.
Oh, thank you. I accept with great pleasure. I hope this has been helpful to people, and I look forward, Alex, to our next moments of meeting.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.